why I don't use psychiatric diagnoses to help my patients with mental health concerns. Now, I'm often asked by people, do you diagnose psychiatric disorders? And the short answer is no, and here's why. So for those of you who do not know me, my name is Fernando Alejandro Rivera. I'm a board-certified physician assistant. I practice family medicine and sports medicine here in Fayetteville, North Carolina. So you might be wondering why people are asking a family medicine guy whether or not he's diagnosing psychiatric disorders, right? Well, most people would be surprised to find out that the majority of mental health care actually takes place in the primary care setting. And PAs, we get trained on how to diagnose psychiatric disorders in accordance with the American Psychiatric Association's Diagnostic and Statistical Manual, DSM. But despite that, I choose not to use it to diagnose my patients. And there's really two practical reasons for this. The first is that the DSM was never really designed to guide treatment in the way that other medical diagnoses do. So, for example, if you come in with shortness of breath, you may be experiencing an asthma attack, a COPD exacerbation, pneumonia, a pulmonary embolism, a heart attack. Getting the right diagnosis for these kinds of conditions is essential because it's going to determine the way that I'm going to treat you. Each of these diagnoses describes the process that's going on that's causing the shortness of breath. And so getting it right will say, do you need antibiotics? Do you need a bronchodilator? Do you need blood thinners? Is this an emergency and you need emergency intervention? But the DSM doesn't work that way. What I'm going to read to you is from the most recent version of the DSM-5 text revision published in 2022. Here's what it says. Since a complete description of the underlying pathological processes is not possible for most mental disorders, it is important to emphasize that the current diagnostic criteria are the best available description of how mental disorders are expressed and can be recognized by trained clinicians. So in other words, the DSM does not actually define the underlying processes that are going on with these disorders. It's simply describing the patterns of symptoms and assigning names to these cluster of symptoms. Unlike medical diagnoses that reveal the underlying mechanism behind the disease, the DSM diagnoses are really just subjective naming of clusters of symptoms and categorizing these symptoms. This means that they don't tell us the cause, nor do they necessarily dictate the best course of treatment. The second reason that I don't use the DSM is that among many purposes of the text, one of those is billing purposes, right? And so if you get treated in the United States and your clinician wants to be reimbursed by an insurance company, they need to use something called ICD codes, or International Classification of Disease codes. And the DSM provides these billing codes. But the thing is, I have a direct primary care practice where my patients are members. They pay a once-a-month fee, and that covers all of their visits for any kind of care that they receive. I do not bill insurance. I do not get insurance to reimburse me for the care I provide, so I don't need the billing codes. Now, this does bring up an important question that often comes up when we talk about mental health. Does research prove that psychiatric disorders, according to the DSM, are actual diseases? A lot of people are under the impression that modern research in psychiatry is showing that there's actual changes in the brain and that is evidence that these DSM diagnoses are real disease. Here's part of the difficulty with that. First of all, much of modern research in psychiatry first utilizes the DSM to diagnose participants, and then in accordance with that criteria, picks participants for their study. So what that means is that from the very beginning of the research, the people going in and getting brain imaging and electrical, pattern checks and stuff like that have already been diagnosed in accordance with the DSM criteria. So that means that they're not looking at brain imaging and then from there trying to diagnose a condition. That diagnosis has already been given before they even scan the brain. So when researchers say we found differences in brain function in people with depression, what they're really saying is we found differences in brain function with people who have been labeled with depression in accordance with the DSM. Now, that doesn't tell us if those differences are what caused the depression or if it's the thought patterns that manifest themselves in the ruminating that has led to the changes in brain function. Another thing is that this research doesn't tell us if those changes that have been observed are permanent changes or they're just kind of there right now because of what the patients or the participants have going on. In fact, most psychiatric research really shows us brain activity and not necessarily changes in brain structure. Now, let's be clear. We do understand that if activity in the body stays a certain way, it can change the tissues of whatever it is, just like exercise can change muscle size or, a resistance training can build bone density, right? For example, London taxi drivers do have an enlarged hippocampus, believed to be attributed to the fact that they're always navigating and they're using that part of the brain to help with navigating. The question is, did their hippocampus become enlarged and therefore they became taxi drivers? Or is it the requirement of a taxi driver to be navigating causing increased activity in the hippocampus, which leads to growing of that region of the brain? Other studies have shown that people who practice mindfulness and meditation, engaging the prefrontal cortex, actually have an enlarged prefrontal cortex, right? And then we see some signs that people who are considered chronic worriers have increased amygdala activity. Now, does that mean that they have a disease called anxiety where the amygdala, it takes over the amygdala causing the worrying? Or is that constant rumination causing the increased activity in the amygdala? The DSM doesn't answer that question. Another important point that I've talked about a lot, because not enough people understand this, is DSM diagnoses depend on culture, not biology. Let me explain. The DSM itself acknowledges that what we consider disorders actually depends on cultures. I'm about to read to you from the preface of the most recent DSM. It says, the boundaries between normality and pathology vary across cultural contexts for specific types of behavior. The threshold of tolerance for specific symptoms or behaviors differs across cultural contexts, social settings, and families. Now, this is essential. Check it out. If you have a broken leg, your leg is broken whether you're in the US, Japan, or Nigeria. If you have diabetes, it doesn't matter what your culture is, you have diabetes. But according to the DSM, whether or not you have a mental disorder depends on culture, your family expectations, and social settings. Now, this doesn't mean that people don't suffer from a tremendous amount of fear or anxiousness and even a deep state of sadness. That's not what that means. It just means that the way that we classify these conditions is actually a social construct more than it is biologically fixed, at least according to the DSM. Now, does this mean that mental health struggles aren't real? Absolutely not. People absolutely experience anxiousness and a depressed mood and other difficulties with their mental health, difficulty with focusing at various different settings. Absolutely. I work with patients every day who feel trapped with overwhelming emotions and intrusive thoughts and cycles of suffering. And I myself am very familiar with experiencing that anxiousness and the chest discomfort and the inability to catch your breath. But calling something depression or anxiety, according to the DSM, doesn't actually tell us what's going on inside a person's body or mind. That's why in my practice, I focus on getting to know my patients, their stories, their culture, their values, their beliefs, trying to get a sense of what is going on in their life that is contributing to the manifestation of these symptoms. And for many of my patients, simply shifting their beliefs regarding what they're experiencing can be very dramatic and impactful. Now, some final thoughts. I do understand that many people feel validated by a DSM diagnosis, and I respect that. I just feel that people deserve more than just a label for their symptoms. I believe that they need something that helps to empower them, to help that they can feel like they can make a change, rather than just getting a label that makes them feel broken. So that's why I don't use the DSM. Now, again, if you're listening to this and you're wondering, what do I need a diagnosis? Maybe I need to share my story. Maybe I need somebody who's going to listen. I'm happy to meet with you. I'm over here in Fayetteville, North Carolina, at True Care DPC. And thank you so much, guys, for taking the time to watch this. And I hope this clarifies that for many of you who have asked. God bless y'all. Take care.